Dan, very excited for our guest today. We get to speak with Laura Adams, Special Advisor to the National Academy of Medicine. You might remember her from our Patient Engagement Summit a few years ago. She was previously the founding president and CEO of the Rhode Island Quality Institute, and she's also the principal of Laura Adams Consulting. So we've got another great guest to interview today.
Yeah, this will be exciting. Why don't we jump right into the interview?
Sounds great. So Laura, in the few years since you joined us at our Patient Engagement Summit, tell us some of the things you've been up to.
Sure. I think your summit was before 2019, which is the year that I stepped down as president and CEO of the Rhode Island Quality Institute, Rhode Island's Health Information Exchange. And after 17 years of just terrific experience and opportunity there, I became a special advisor at the National Academy of Medicine, where I now provide leadership into their science and technology portfolios. That includes digital health, artificial intelligence, and evidence mobilization. And I see the industry and the world from a very different perspective now, a more global perspective, and certainly one that in some cases comes a little deeper in areas that I didn't have as much experience in, being immersed in HIE.
That is quite the array of technologies and efforts you're putting together. So any specific projects you're working on, the efforts that the Academy is involved in that you want to share with us?
Yeah, I think that some of the most exciting work to come out of the academies right now is we're in the middle of publishing a group of 9 COVID-19 sector assessment papers. And this is a look back over what did we learn during the catastrophe that was the pandemic and where we had shortfalls in every sector. So that would be things like payment, that would be health products manufacturing and innovators, that would be digital health, quality, safety and standards research and so forth, patients and families, delivery systems. And we had an array of leaders across the country giving their perspectives into those papers, and we're publishing them now. And it's quite a call to action when we think about what it is that we want to benefit from in terms of our learning from COVID-19 and things we never want to repeat.
My goodness, what a time it's been. I wonder if some of our listeners would be interested in accessing some of those papers. Do you have any guidance what they could do if they're interested in learning more about that?
Certainly, you can search the National Academy of Medicine COVID-19 sector assessments, and that will come up. And we have 2 of them published now, and 2 of them that are, actually 4 are published already, and 2 of them are coming up in July.
Oh, appreciate you sharing that. So Laura, one thing that we really enjoyed when you joined us at our summit, your background, and you talked about things you have done to help focus on the patient. As you know, this podcast is intended to really amplify the patient's voice. How do we listen more to the patient? How do we involve them? Can you share a little bit of your background and where that's been a part of your passion in healthcare?
Oh, Adam, I'd be happy to. Those of you that know me know that very early in my career as a young nurse working in a rural hospital of only 30 beds, if you counted all of the seats in the waiting room, it was 35 beds. And that small hospital, I was a night shift nurse, and coming off staff one night, coming off shift, I heard the intercom come on downstairs with our one surgeon who sounded ominous in terms of the tone of his voice. I knew something was wrong. Something was wrong, all right. I had given a catastrophic overdose of a dangerous drug to a 7-year-old child, and she was in the throes of that in the operating room. I'll never forget running over to the intercom and telling him I was still here, and he said, "You need to find out what you gave this child pre-op, because there's something wrong down here. She's seizing, she's in a coma, and I think it had to do with her pre-op." I felt like the life drained out of me at that moment, and I raced over to the medication area. I looked down and I saw instantly that I'd given her a 10 times overdose of the drug scopolamine. Now, an overdose, that drug causes seizures, coma, and death. And this is in a pediatric patient. So I was quite concerned that she was headed for number 3. By the grace of God, the powers of the universe, or whatever, that child's life was saved by that care team that day. I'll be forever grateful that that happened. But my experience with that was life-changing for me, to look into those parents' face, to explain what happened, to express my just the sorrow that I felt, and I felt deep sorrow and remorse for having made that medical error. The hospital let me go home for a couple days, and when I finally emerged from a darkened room and got my bearings, I thought, how did this happen? How in the world did this happen? I'm at least, above average intelligence. I think I was cut out to do this work. And when I went back and looked at the process that led to that event, I realized that that order had been hand transcribed 6 times before it came to me as the night shift nurse. And hand transcribed, just like the telephone game, 2 times by people with no pharmacological background, not knowing that moving a decimal point, that could be death by decimal point, especially in a pediatric patient. So that was one of my earliest experiences. And then when I gave birth to my son, Ben, after waiting many years for his arrival, I took him in for his immunizations. And by that time I was wary because I knew how the fallibility of the delivery system and how easy it was to make medical errors. I'd made one myself. And I was a bit concerned about karma, maybe. So they're approaching my little one, newborn, with a big long needle, and I'm hoping it's the right dose, the right drug, the right everything, because they had my whole life in their hands. And I realized the intense vulnerability of a patient, even at that moment of a newborn vaccine. And then as time went on, and I began to realize that patient centricity was not necessarily the driving force behind what we did in healthcare. It became just painfully apparent to me when I myself realized where I was headed. I think one of the most powerful forces in healthcare that shaped us over time and still does is the payment model, and it's toxic. That payment model for the longest time rewarded volume and not value. Very, very little relationship to quality, if any. It was the more that we produced, did not have to produce quality to get paid well. And I remember walking into my hospital in New Orleans and staying every day. I would come in and say, oh, heads and beds. Oh, good. We're bursting at the seams. Excellent. Lots of people are sick. Oh, wait, the operating room list. Are we full? Super. So the surgery list is full. Great. Oh, we had a bad trauma last night. Oh, they were insured? Oh, terrific. Okay, great. And then I remember bounding, and I mean bounding into an office one day. We're filled full of my team members. And I was excitedly exclaiming to them that I had just heard coming into work that morning that it was going to be a very bad flu season. And I looked at them with glee and I said, we will so make budget, right? And I don't know what caused me to start waking up and thinking, why am I cheering illness and infirmary this way? And I started to deeply question myself around that and realized that that's how we made money at our hospital. That's how we kept things afloat. And later on, when I began to develop technologies, and I had a hospital administrator, we built this phenomenal technology that allowed people to keep patients out of the hospital when they didn't need to be because their care was better coordinated. And that CEO said to me, Laura, I'd love to use your stuff, but I can't. And he said, the reason that I can't is because when my doctors use it in the outpatient setting, those patients don't get admitted, and I need that revenue. And I began to realize that the payment model had this chilling effect on our adoption of technology and certainly on our ability to be patient-centered. So I think bad systems bring out the worst in good people. Nobody is greedy, avaricious, or evil or goes in with that intent, but I know how it shaped me.
I think you just described a perfect symbol of where healthcare's been and hopefully where it's improving and gravitating towards on a very personal level. You know, as we think of patient centricity, we're very interested in your perspective. Today, looking at 2021 and beyond, if you could change something about our healthcare system that would make things immediately more patient-centric, what comes to mind from your perspective?
Oh, if I could just wave a magic wand. But if I could, what I would do, I would make patient centricity the absolute North Star of all of our designs, of all of our innovations, of all of the development of our products. That would be the benefit to the patient. That would mean inclusion in design, inclusion in the execution and testing of those, inclusion in the innovation and upgrading of those, and then transparency around how they perform vis-a-vis value. I would have that be the absolute key design principle. I recognize that efficiency and making sure that we can bill and those sorts of things are important, but I feel like we've swung the pendulum way, way, way more toward not necessarily the efficiency, but certainly for optimizing payment and not necessarily for doing what was in the best interest of patients. And you can see it every day in the design of our systems that so demoralize our workforce. And I think, boy, if we ever think we're going to transform this healthcare system and make it patient-centric with a demoralized workforce, I think we're wrong. And so it feels to me almost as if we were to align around that design principle as the key design principle. I think it might have something to do with lowering frustration levels on the part of clinicians who at their heart want to do the best for their patients.
That's very interesting. Have you seen any recent examples of new patient-centric technologies that get you excited or put a smile on your face as you think about some of the challenges we have in the industry?
You know, I think one of the most exciting ones that has to do with a phenomenal use of AI and computational biology is an organization called Inflamatics out of California, out of Burlingame, California. What they're doing is transcriptomics, where they're actually reading the response of the immune system way ahead of when we ordinarily pick up that immune response in the bloodstream. And so they're able to detect a pathogen and be able to predict its toxicity or its the severity of illness coming out of that. So when we think of the implications for things like sepsis or COVID-19, to actually find out what's going on with that patient, identify the pathogen and its trajectory clinically earlier than it ever landing in the bloodstream, we start to realize we can make decisions so much earlier. It can pick up whether something is viral or bacterial. And so I'm watching this phenomenal use of AI. Sepsis is one of the biggest killers globally, without a doubt, hands down. And I will bet you, if you knew the true story behind sepsis's carnage, you would know somebody whose life has been taken prematurely by sepsis. People will say, oh, they got an infection or this, that, and we often don't know, especially the public doesn't know the scourge that sepsis is. So when I look at something like that, I think that's very much patient-centric. But one that I would also like to point out is, and I know that people will probably claim a bias here, and I will cop to that bias, but if we didn't see the power of HIEs, health information exchanges, before COVID-19, we saw the power of them now. Boy, I can say that when I think they were on full display, when I think of Jamie Bland and Sync Health out of Nebraska, I think it was formerly the Nebraska Health Information Initiative, now Sync Health. They changed their name because they're regional now, and they are so much more than an HIE. They have taken those data assets, and they are now a full-on public utility for health data. I had a call with Jamie a while back, and I was just practically, I was amazed at the work that they've been doing. And HIEs are inherently patient-centric because you have to get everybody in your region collaborating. And that means people who are sworn enemies, natural enemies in the wild, people who can't stand to breathe the same air sometimes because they're competing so fiercely in their communities. They all come together, they agree that they're not going to compete on something that literally patients' lives depend on. And then I watch their efficiency levels go up, their ability to enact things in public health go up. And I'm starting to think the benefit to the patients that pouring out of HIEs like Jamie's, just unbelievable. So yeah, I was a believer in them before, and I'm really a believer in them now.
Such an important concept of sharing data and looking to the greater good. And I'll just insert parenthetically, class is working on an initiative to help measure interoperability efforts. And boy, something we'd love to share with our listeners, with you specifically, Laura, but we would agree with you. What a crucial part of improving healthcare, just getting the data across the street where it's needed.
No question about it. And when you think about the repositories and how you can begin, if we really plumb those things, if we overlay the right kinds of AI on top of that, we don't have to wait for some national report to come out to tell us how people in our region are doing. We know those early signals of things that are firing off. We could probably detect so much more about the next pandemic because we are now primed to be able to develop the technologies to look into that data and let the data speak back to us, to tell us things that it sees before we even know to ask the question. So I'm just wildly enthusiastic about those, always have been, but even more so now after the pandemic.
I want to go back to something you were talking about, the universal challenge and just the state of healthcare with sepsis and how critical that is to get under control. You know, so much of our research has shown us that what the patient needs or what the patient is focused on does not always align with what providers are focused on. And you've given some great examples there. Laura, I'm curious your opinion on this statement. It seems that as we focus on the patient, it can help align to the outcomes and goals of providers. Perhaps they're misaligned on some areas of focus, but by taking care of the patient, we ultimately do achieve the outcomes that are typically sought after. Any response or thought to that?
Oh, Adam, I couldn't agree with that more, because I think that when we feel as if sometimes we've lost that connection to the patient. I'll never forget a drawing a little girl made from Hasbro Hospital, and she was just reflecting. I think she may have been 6 or 7 years old, and it's a crayon scribble, and she was just depicting her experience with her physician in the office visit. She's on the exam table, seated there with a smile. Her mother's next to her with a big smile. Where is her provider in that picture? Over in the corner, hunched over a computer with, his back to the patient. And that wasn't that little girl's attempt to take a swipe at EHRs. That was her sense of her visit with her clinician. No clinician wants that or enjoys that or feels like they want something intruding on that deep and sacred relationship. So that the more that we can begin to build these systems such that we can engage the patient, so they are yes, a billing tool. We understand the importance of that, especially as long as we have to bill for every little piece and part that we do. But when it becomes more of a global payment situation where we really do get paid for the health and well-being of those that we serve, you can see that alignment. And I can see it aligning because these physicians and nurses and team members, all the team members, care team members, want to practice at the top of their humanity. And when technology enables that, it enables that ability to sit in presence with that patient, listening to every word they have to say, being with them in that moment, where you can communicate compassion in an inimitable way at that time. And the patients and the families feel it. And I think it has everything to do with healing, both the clinician and their sense of burnout and the patient and their health challenge.
That's very interesting. If you were to summarize or to give advice to both vendors and provider organizations on how to be more patient-centric and to put the patient first, what advice would you give to those two groups?
I think my advice to those two groups would be to remove yourself from your own experience to the extent that you can, and don't rely on other people to tell you what they think the patients want or need. I got to say that the most passionate, creative, dedicated, and innovative people I've ever seen are extraordinarily close to the reality of the patient experience. And by that, I mean that they either have gone through something horrific themselves, somebody that they love has gone through it. They have a burning passion, often for a lifetime, to improve the system. And it could be someone close to them. My advice would be to seek those experiences, even if that person that's close to you is just the person who's seated in the airplane next to you. When I was doing the work in patient-centeredness in a deep, deep dive, all I would have to do is ask the person on the plane next to me, did you have any experience with the healthcare system? And I was good for the next couple of hours, just taking notes on what they were saying. When people are willing to share their experiences about it, doing that deep dive into that experience is forever changing a person, because you can't help but, especially if they're close to you. My transformational experience was started the day I got that diagnosis of breast cancer. I had never been a patient of any type or sort prior to that. Yes, I gave birth to my son, but I had really never been a patient beyond that. Well, tonsils out maybe. But So I get that diagnosis, and suddenly there's this flurry of activity. And my little Excel spreadsheet where I kept all of my patient record longitudinally went out the window because I was seen at 7 different places. The records didn't speak to each other, and suddenly I lost complete control of my own little longitudinal medical record. And then I began to understand in this deepened way, wow, that health information exchange thing that you've been building, it matters more than you ever knew. So as my course went on in my treatment and during my surgery, I'm losing a body part, but I'm not losing my life. They're lowering that anesthesia mask to my face, and I start to react, trying to get their attention. They lower it anyway and anesthetize me. What I was trying to let them know is that, yes, I did bring my advance directive, but it's on a piece of paper. And it was folded up in my purse, which was locked in a cubby, and nobody knew where it was. So if something, heaven forbid, had happened to me, I wanted my organs shared far and wide, but that would not have happened because once I woke up from anesthesia, got my bearings, I thought, if you survive this episode with cancer, you get yourself back down to Rhode Island down there, and you figure out a way for patients to upload the documents that they think are important to their record. This blockchain technology, yeah, get up to speed on it because I think it's going to matter. You're going to need that for something like an advance directive. And then over time, as I began to realize how much I needed to look at my record, and it was in all these pieces, I realized, you know what? You have in Rhode Island spent all this time amassing this data to show to clinicians, never once thinking about opening up that longitudinal record to the patient to whom it belongs. And so I thought, again, if you survive this bout with cancer, you get down there and you make it so that patients can get in, download, send that to Scottsdale, wherever it is that they want to send their record, put it on a USB drive, it's theirs. They have control over it, and they should be able to route it any place that they want or need, because not everybody has an HIE. So it was only when I got immersed in my own illness did I understand that I had phenomenal blind spots, even after a career of priding myself on being patient-centric. So my lesson would be, whenever you can get into those experiences, listen with your whole self, with your whole being. Take it in, because it will change the way you approach every other aspect of your work. Once you get that understanding, put it to work. So I think my feeling about that would be that immersion pays off.
Well, I don't know if you have any petitions you need us to sign or groups to join, Laura. We're in. We're in. Your passion comes through brilliantly, and we just so appreciate your leadership. And Dan, I think we could go another 3 hours with Laura here and just try to learn from her. As we wrap up, would love to hear any final thoughts. Again, thank you so much for joining us, but anything else you want to share with our listeners beyond what we've already covered today?
I just want to thank you for the opportunity. It is an opportunity and it's an honor to come on. I am a friend of class. You've done so much for the industry. I relied on you so heavily in Rhode Island, and I sing your praises every chance I get because you're a contribution to the industry. And I think that, I guess if I were to make a last statement around patient-centeredness, it would be a plea to make the patient the North Star. And if we do, all the other stars align.
It's wonderful. Thank you so much, Laura. Again, we're honored to have you here. Thanks for all your great work. I'm sure our paths will cross again soon.
Oh, I hope so. Thank you so much, Adam.
Thank you.
Well, Adam, Laura was a really fun guest to hear from today, and it's fun to hear everybody's experiences of how their prior healthcare journeys have shaped who they are today, shaped their career paths, and shaped how they view incorporating the patient voice into what they do.
We're really seeing a pattern there, aren't we? I'm thinking of other guests that have been on the podcast, and more often than not, they've had some kind of journey experience that really gravitates them towards being more patient-centric. Yeah, I agree. Loved hearing from Laura. What a leader in the industry, and so glad we could talk with her.
Yeah, it was fun to hear how she talked about some of the people in the industry that she's met that are so passionate about what they do. How it almost always ties back to one of those experiences that really shaped how they think about delivering care, how they think about the patient experience.
I think I'll always remember in today's episode the image of an anesthesia mask going over a patient that's trying to participate in their care, trying to engage. And I don't know if that'll be a symbol of this, but we've got to listen more. We've got to pay attention. We've got to involve them and find those technologies that really are focused on the patient. So.
Right. Well, Adam, we always like to have a short minute where we talk about things we're overhearing at class. Has there been anything you've heard on a recent research interview or conversation you've had?
Yes. Yeah, I was excited to share with you some conversations we've had with a very large health system that reached out to us. And as you know, there are many solutions out on the market. And they reached out and said, we need your help to navigate the craziness of patient engagement. And to them, that meant there's so many things, and post-COVID, it's a new world. It is absolutely a different time in healthcare, and organizations are trying to figure it out. So they reached out and said, we need some guidance. So we taught them how to fish on our website a little bit, gave them access to some of the class reports. We asked them what they're doing and anything they're developing, and they sheepishly said, yeah, we haven't really involved any patients on things we're trying to do. And so further evidence that we're not quite there, and it's coming along, but we're happy that people care and they're trying. So that was just last week.
It was interesting to hear, even for an organization that large, how little focus there was on amplifying the voice of the patient, which is what we're trying to do here.
Right. Okay, well, I wanted to ask you about some of the class research. Obviously, that's a major part of our roles, what we do at class. And anything that jumped out at you this past week?
Yeah, I was having a conversation about digital front doors, and this is an active project that we're working on, trying to help the industry to navigate what a digital front door is, where it starts, where it ends, and what should be included in their efforts. And as I've had repeated conversations, a consistent theme that's coming up is how core the portal and the EMR vendor are to their strategies. This isn't something that they're doing alongside the EMR vendor. This is really something that's centralized around portals, and they're building additional consumer-centric capabilities on top of that. One specific example that stuck out to me this week, I was talking to a healthcare provider organization that shared, I asked them, how do you define a digital front door? And he said, well, this isn't really just a digital front door. We look at it as all the different ways a patient can enter our organization. They might be coming in through the windows, they might be coming in through the back door, but we're trying to create a lot of entry points for them to just navigate the experience as seamlessly as possible.
Wow, awesome. Appreciate you sharing that. Yeah, that's a report that we're focused on, and hopefully can add some insights to our provider friends out there. Well, Dan, like always, I have a parting quote I want to share with you.
Well, I'm excited to hear it.
You remember the movie Patch Adams, played by Robin Williams? Well, the real Patch Adams, Dr. Adams, said, "See what no one else sees. See what everyone chooses not to see out of fear, conformity, or laziness. See the whole world anew each day." Great reminder. Healthcare is not the same as it was and needs to be different, right? For reasons that Laura shared with us today. We need to focus on value, we need to focus on the patient, we need to involve them at all steps. So there's my quote I want to share with you.
Love it. What a great way to end. We'd like to just thank Laura again for participating today and sharing her insights with us. Thanks to our colleague Jeff Peterson for helping coordinate the technology around this experience, and we're excited to participate with you again on an upcoming episode.
If you have any ideas of topics or guests that you'd like to see on the podcast, as always, please reach out to our email address, patientengagement@classresearch.com. Until next time, thanks for joining us.